Okay, good morning, everyone. From Physicians for Peace, that is a sponsoring organization for this, and from Seattle Children's Hospital. Thank you very much for inviting me, Satish. It looks like an interesting day ahead of us. So I will start this session by just giving a short summary on things that you can think about in managing the patient with refractory hypoxemia. Some of these are pretty basic, and others require a little more thought, but please bear with me as I think all of these points are worth some consideration. So when we think about the causes of hypoxemia, we go back to basic physiology, which I guess we're addressing in the other session, and think about the primary causes that include low oxygen, if you're on the top of a mountain, hypoventilation, which also will affect carbon dioxide, a diffusion defect, which is relatively rare, and then ventilation perfusion mismatching, and shunt. All of these will lead to hypoxemia. So I'm just going to start and go through what I think are the basics and then more subtle points to consider when managing a patient with hypoxemia. So when this child presents in the emergency department, they may not even be intubated or have the benefit of oxygen. So the first thing that we always need to think about is make sure that we have a conducting airway to deliver the oxygen to the lungs. These are basic PALS recommendations, but above and beyond the jaw thrust in the intensive care unit, we often have to consider keeping that proximal airway open with suctioning or even sometimes bronchoalveolar lavage, such as in children with respiratory distress syndrome. Well, we want to increase the oxygen as best we can to maintain an adequate saturation, but I think we need to remember that there is a cost for everything, and with high levels of oxygen, there is always the possibility of oxygen toxicity through generation of superoxide anion and then all of the other reactive oxygen species. And this occurs at a number of places biochemically, in the mitochondria, in the phagocytic respiratory burst, in the process of metabolism of eicosanoids, and in ischemia reperfusion reactions. So use oxygen, but if you can wean it to get it to a lower concentration, do that as soon as possible. On the other hand, avoid 100% oxygen. I think this concept of resorption atelectasis is well known in neonatology. I think sometimes we forget about it in pediatrics. But if you have a lung unit that is poorly ventilated and you are giving 100% oxygen, that poorly ventilated alveolar unit will absorb the oxygen completely and become atelectatic. So addition of some nitrogen into the inspired gas is usually beneficial. If a patient requires 100% oxygen, it is likely that you can reduce it to 90 or 80% right off the bat, because most of this is probably shunt, and turning the oxygen to 100% for long term will not make any difference anyway. So wean the oxygen as you can. Well, then the most basic step for most lung diseases that we encounter is recruiting alveoli that are atelectatic. And what we want to do basically in terms of physiology is thinking about the relationship between pressure and volume, and I'll show you this in a few seconds, and titrate the patient with pressure to that area on the pressure volume curve where there is maximum slope. And just bear with me, I'll show you this in a second. So basically in changing the ventilator, we want to basically titrate the positive end expiratory pressure beyond the inspiratory inflection point. This is easy to talk about, but in actuality, maybe not so easy to do. But we're trying to maximize at the same time the pulse oximetry saturation and lung compliance, the milliliters per centimeter of water pressure delivered. For these types of problems, only pressure fixes shunt. That is, you can't make this better by increasing the FiO2. You have to recruit the alveoli. Look at the chest x-ray. This is particularly important in terms of making sure that you are not over-distending the lung. And then lastly, take a look at the concept that although you may improve saturation and oxygenation, at the same time you may be impairing oxygen delivery. So ultimately you want the best positive end expiratory pressure that is associated with the best oxygen delivery. Sorry. Get this back up. A depiction of the concept of shunt that you can find in any physiology textbook. With no shunt here, you can see that you get a nice response to improving arterial PO2 and alveolar PO2 with inspired oxygen concentration. But as the shunt increases, this is less and less effective and ultimately makes no difference in improving oxygenation. You need to recruit alveoli. So this relationship I was talking about on the pressure-volume curve, with pressure on the x-axis and lung volume on the y-axis. And you see this curvilinear relationship. And when we are trying to recruit alveoli, we are trying to aim or target this sweet spot for the maximal change in volume with a change in pressure. We don't want to overdo this in terms of overstretching the lung, because this will lead to volume trauma. And at the same time, we don't want to underdo this by utilizing too low of a PEEP, because this will lead to repetitive atelectasis, re-expansion, and something that is called atelectrauma. So we try to adjust the PEEP here to achieve the maximum compliance, change in volume over change in pressure, and a corresponding best saturation by oximetry. So in terms of those two extremes, the atelectasis or the atelectrauma, avoiding a PEEP that is too low so that we do not have this repeated closed and open shear stress injury, keeping the lung open during both inhalation and exhalation, as opposed to atelectasis during exhalation. And on the other hand, not so much positive end expiratory pressure that we are on the flat portion of the volume pressure relationship, because here this will lead to a situation where there is no further recruitment, no further increase in lung volume for the change in pressure. And as you can see by these photoelectron micrographs, there is actually injury to the alveolar capillary membrane and atelectrauma, as well as injury to the capillary epithelium and endothelium in this type of a situation. So this is this very delicate interface shown here on an electron micrograph between the alveolus and the pulmonary capillaries that course through the lungs. So we want to have adequate alveolar recruitment, so these alveoli are open, but not so much pressure that this is actually impinging on the pulmonary capillaries. Here is another view of the same thing of the pulmonary capillaries with red cells coming through these capillaries, and the alveolar portion of this airway or gas exchange unit. And you can see that if the alveolar pressure or volume is increased, ultimately it's going to impinge on these capillaries and decrease blood flow through the lung. This is called alveolar capillary blockade, and it results in dead space ventilation. So there are clues for this concept of dead space with excessive mean airway pressure, and they are that on your end tidal carbon dioxide, this value will progressively decrease. You may see evidence of impaired cardiac output, such as increased lactate, if you're measuring that. The pulse waveform will vary depending upon the portion of the ventilatory cycle that you are in, indicating that this patient may benefit from some volume expansion to reperfuse these pulmonary capillaries, and then actual decreased cardiac output if you were measuring it. Here is the equation for dead space ventilation that is easily calculated. The end tidal carbon dioxide minus the arterial divided by the end tidal. This is something that we should be keeping track of as we are manipulating these pressures in the lungs, trying to optimize alveolar recruitment. Moving on to fluid status, this is one of my favorite things because it affects these concepts that we've been talking about. Ideally, we would aim for a euvolemic fluid status in these patients. If these patients are too wet, this will lead to alterations in surfactant, atelectasis, and increase in shunt. And if these patients are too dry, this will lead to this phenomena of capillary blockade and increased alveolar dead space. So a lung that is too wet on the left, you can see that this would be a lung that would be non-compliant and perhaps difficult to recruit. And on the other hand, excessive mean airway pressure in relation probably to volume status, and you would expect that a patient like this would be one that would exhibit increased pulmonary dead space. There's a lot of evidence now about this concept of volume status in critically ill patients, and I'm just going to show you 3 examples of this with the idea that less water, less volume overall during a patient's stay in the ICU is better. So this is one graph from a paper by a pediatric nephrologist and a group that he was leading, just showing that at the time patients were put on renal replacement therapy because their kidneys were failing, those with a higher fluid excess status had worse outcomes. So the survivors with about a 16% fluid overload and the non-survivors about twice that level. Gosh, I did it again. Slow to learn. This idea of fluid status, actual dose-response relationships that have been demonstrated. That is, the higher, that's good, okay, thanks. The higher the fluid overload, the greater the risk of death, and that is shown in this slide here. Even in studies that have been done in adults, the ARDS network FACT trial, the patients with the most conservative fluid balance were the ones that fared the best in terms of outcome. This is another pediatric study showing children in intensive care units, all patients and those with multiple organ dysfunction syndrome, and then those with greater than 3 organ dysfunctions. And in every case, the survivors had a less positive fluid balance as compared to non-survivors. So this is something that we should think about in our practice generally, but specifically with regards to the lung. We need to have an adequate volume present to perfuse the pulmonary capillaries, but not excessive. Here is this dose-response relationship once again. with greater fluid overload associated with worse outcomes, and these are in pediatric critically ill patients. So this is my favorite molecule. This is furosemide. As you know, critical illness is basically a deficiency state of furosemide. I think this, we all utilize this drug frequently, but in terms of managing refractory hypoxemia, it is very valuable. Moving along, ultimately in patients who are very sick, and other people will say more about this, we actually get to the point of approximating the mean airway pressure with the positive end expiratory pressure. That is, keeping the lung expanded, don't allow it to become atelectatic, and reduce the volume shear stress. So basically, getting the lung open and keeping it open. And there's two ways right now that we do this, and this is with the high-frequency oscillatory ventilation or airway pressure release ventilation, and others will talk more about this. Again, we need to make sure that we are perfusing the lungs with adequate blood flow, so in addition to euvolemic volume status, we may end up utilizing other things to improve cardiac output, including vasoactive inotropic agents, and especially for children, we may also utilize pulmonary vasoactive agents such as nitric oxide. With high airway pressures, mean airway pressures, we are at risk of developing these west zones of the lung like type 1 and type 2, where flow through the lung is governed by mean airway pressure, and so this may need to be overcome with additional volume resuscitation or inotropic support. For the lung that is refractory with atelectasis, we can consider providing exogenous surfactant just like we do for neonates. I would have to say that the evidence that this improves long-term outcomes is meager at best, although there's been a couple pediatric studies. But short-term, it does improve alveolar recruitment and oxygenation. This complex conglomerate of molecules, as you know, confers this variable surface tension at the alveolus, but it also has important roles in pulmonary edema, clearance. It regulates local inflammatory responses by acting as an opsonin for pulmonary macrophages, and it is the initiating event for mucociliary clearance from the lung. Well, one of the ways of improving blood flow through the lung is to manage pulmonary hypertension when it occurs, and this is a problem of pediatric and neonatal critical care medicine much more than adults. And again, the evidence outside of the neonatal intensive care unit is meager, but we all have seen, if we've used these molecules, evidence where application of these agents, either nitric oxide or nebulized isoprostanoids, improve oxygenation immediately. So this is a common problem, that is pulmonary hypertension. We can quantitate it with echocardiography, and if we believe pulmonary hypertension is present, we can start nitric oxide at 20 parts per million. Ascertain if it works or not. Is the saturation getting better? This should happen almost immediately. And if it's not, then wean the drug and discontinue it because it's very expensive. Lastly, coming down to the home stretch for some of these patients, and there will be lots more talk about this later this afternoon, is improving the interface between the patient and the ventilator. That is, the patient's how the patient tolerates this mechanical ventilator support. So this may be in terms of adjusting the pressure or the volume support to the patient's needs and preferences, protocolized sedation to facilitate the patient tolerance of this support. Occasionally chemical paralysis may be needed. But recall that immobilization of these patients, corticosteroids, and even aminoglycosides will increase catabolism in these patients who are lying still, and ultimately they will increase proteolysis of lean body muscle, including the diaphragm. So down the road, it may be more difficult to wean this patient from the ventilator. Should consider changing the position of this patient from supine to prone, and there are several advantages that have been demonstrated with this change in positioning to the prone position, and that is that prone improves VQ mismatch in general. It decreases the compression by the heart and the abdominal contents so that functional residual capacitance is increased. It's been associated with decreased ventilator lung injury in animal models, and it is known to improve mobilization of secretions, again going back to the concept of keeping the airways open. If nothing works, we can accept the fact that our saturations may not be exactly what we want them to be. So a low saturation is okay. They don't have